for those of you who don't know, I think this is all campuses, but my name is Michaela, and I am a pediatric inpatient nurse at the Children's Hospital Morgantown. And so I'm basically going to be doing the tutoring, and this tutoring is basically a tip sheet and just like main topics that your test is going to be on every week. So it's very pertinent and can help you with your exams when you're taking them because they can be worded very difficultly and to like trick you. So I'm just going to go ahead and get started. If you guys have questions, just speak up and then we can go through it slowly. But your first test should be pretty easy. It's basically about your developmental stages and things like that, and like minimizing stress for your patients and things like that. So, your first objective is students can explain a general principles of atraumatic care and strategies to minimize stress for pediatric patients. Atraumatic care is a philosophy of providing care that minimizes or eliminates the physical and psychological distress experienced by children and their families in the healthcare setting. It rests on three core principles: preventing or minimizing physical harm, like injury and pain, preventing or minimizing separation from parents slash caregivers, and promoting a sense of control through preparation, choice, and honest communication appropriate to the child's developmental level. Um, Nurses operationalize this by grouping procedures to reduce the number of painful interventions using pharmacologic and non pharmacologic pain management together and never lying to a child about whether something will hurt or not. Clinically, atraumatic care changes how the nurse approaches nearly every task. A treatment room separate from the child's bed slash room is used for painful procedures, so the bed remains a safe place. Procedures are explained in simple, honest, age appropriate language immediately before they happen. The nurse allows choices whenever the choice is safe to give, which arm for the IV, which sticker afterward, because choices restores a sense of control that illness and hospitalization strip away. On the exam, expect scenario items asking you to select the intervention that best reduces psychological trauma and physical pain in a pediatric patient and to recognize atraumatic care as an ongoing framework rather than a single task. Moving on, objective 2. So students can discuss the role of the nurse in promoting family-centered care and therapeutic communication with children and caregivers. So family-centered care recognizes the family, not just the child, as the constant in the child's life and positions the family as active partners in planning and delivering care. Their nurse's role includes collaborating, information sharing, and respecting family strengths, cultural background, and coping styles rather than imposing a single right way to parent through illness. This is distinct from simply being nice to families. It is a structured approach that improves outcomes, reduces parental anxiety, and increases adherence to the discharge plan because the family understands and helped shape it. Um, Therapeutic communication with children must be developmentally tailored. With infants and toddlers, communication is largely nonverbal and directed through the caregiver, using a calm voice and gentle touch. With preschoolers, use simple, concrete words, avoid words with double meanings, and use play/dolls to explain procedures. With school age children, give factual explanations and the why behind procedures since they can reason concretely. With adolescents, offer privacy, speak to them directly rather than only to the parent, and respect their need for confidentiality. Exam items often test whether you can match a communication technique to a developmental stage or identify a non therapeutic response. Objective 3, students can identify developmental stages and describe age appropriate nursing interventions. So, pediatric development is organized into recognized stages, each with characteristics physical, cognitive, and psychosocial milestones. So, infant would be birth to 1 year, which would be trust versus mistrust. Toddler is 1 to 3 years, and that's like the shame slash doubt versus autonomy. Preschooler is 3 to 6 years, and that's initiative versus guilt. School age is 6 to 12 years, and that's industry versus inferity. And adolescence is 12 to 18 years, which is identity versus role confusion. So, using Erickson's psychosocial framework as the organizing structure, most PN/RN exams reference. Knowing the expected milestone for an age allows the nurse to recognize deviations that warrant referral and to select nursing approaches that fit where the child actually is developmentally, not just their chronological age. Um, Age appropriate interventions flow directly from stage. For the toddler in autonomy versus shame slash doubt, offer limited choices and expect ritualistic behavior and separation anxiety as normal, not pathological. For the preschooler in initiative and guilt, use magical thinking awareness. Um, for the school age child in industry versus inferity, involve them in their own care and praise competence to protect self esteem. And then for the adolescent in identity versus role confusion, protect body image and peer connection wherever possible. Expect exam questions presenting a child's age and behavior and asking you to identify the expected developmental stage or the intervention that matches it. Try to remember when you guys are answering those questions on your exam, do not think of your children and what they do, because you will get the answer wrong. Because in this world, it's a perfect world for your test. Objective 4, students can discuss the impact of hospitalization on children of different developmental levels. So, hospitalization is a significant stressor at every age, but manifests differently by developmental stage. Infants primarily fear separation from the primary caregiver, which can disrupt attachment and trust information. Toddlers experience the most intense separation anxiety of any age group, progressing through three observable phases. So, protest, which is crying, screaming, clinging. Despair is withdrawn, quiet, appears settled, but is actually depressed. And detachment, which is superficial adjustment that can signal resignation, sorry, not resolution. This stage is often misread by inexperienced staff as improvement. Um, Preschoolers fear bodily injury and mutilation and may regress to earlier behaviors like thumb sucking or bedwetting under stress, which is a normal coping mechanism, not a setback to be punished. School age children fear loss of control, so loss of peer status and bodily harm, and often cope by seeking information and mastery over their situation. This is why teaching them the how and why of procedures is therapeutically effective at this age. Adolescents fear loss of independence, altered body image, and separation from peers more than separation from parents, and may respond to hospitalization with anger, denial, or noncompliance as they struggle against the loss of control over their own body and schedule. The nurse anticipates these stage specific responses, normalizes regression when developmentally expected, and structures the environment to counter each age group's primary fear. On your test, items frequently present a regressive or anxious behavior and ask you to identify it as an expected age appropriate coping response rather than a psychiatric concern. Um, Objective 5, students can explain priority patient and family education related to pediatric chronic illnesses. So, chronic illness in childhood, which would be asthma, type 1 diabetes, congenital heart defects, cystic fibrosis, or seizure disorder, requires education that extends beyond the acute episode to lifelong self management, and the priority shifts as the child matures. Parents are the primary learners and caregivers for infants slash toddlers, but by school age, the child should begin participating in self care tasks such as checking the blood glucose, using an inhaler correctly under supervision with the goal of full self management skill by adolescence. Nurses assess the families and, when age appropriate, the child's readiness and health literacy before teaching and prioritize safety critical content first, recognizing emergency signs like hypoglycemia, respiratory distress, or seizure activity, what to do about them, and when to call 911 versus the provider. Education must also address the psychosocial burden chronic illnesses places on the whole family, siblings' needs, financial strain, and the child's desire to be normal among peers, and connect families to community resources. On exams, priority setting questions about chronic illness, education typically reward the option that addresses immediate safety over general disease information and reward teaching that builds the child's own developmentally appropriate self management skill rather than keeping the parent as the sole caregiver indefinitely. Objective 6 is students can identify safety considerations and injury prevention strategies for each pediatric age group. So, unintentional injury is the lead causing of death in children beyond infancy, and the leading mechanism of injury changes pr- uh, predictably with developmental capability. Infants are at highest risk for suffocation, choking, falls, and motor vehicle injury. Safety teaching centers on safe sleep, and never leaving an infant unattended on an elevated surface. Toddlers who are newly mobile and lack danger awareness are at the highest risk for poisoning, drowning, falls, and burns. Anticipatory guidance includes poison control, number posting, cabinet locks, pool fencing slash constant supervision near any water, and turning pot handles inward. Preschoolers continue to need supervision near traffic and water and are at risk from playground equipment and pedestrian injury as their motor skills outpace their judgment. School age children face bicycles, sports, and pedestrian injuries, making helmet use and traffic safety education the priority teaching points. Adolescents face the highest risk for motor vehicle crashes, substance use, and firearms. So, safety teaching should shift towards seatbelt use, graduated driver's license rules, and screening for risk behaviors. Car seat boosters and seatbelt transition criteria um, is a frequently tested concrete fact. Know the sequence and the reasoning. Um, Objective 7, students can discuss the influence of cultural, social, and community factors on child health outcomes. So, a family's culture shapes health beliefs, illness explanations, help seeking behavior, dietary practices, pain expression, and acceptance of Western medical interventions. And the nurse must assess these beliefs without judgment before planning culturally congruent care. Social determinants, parental education, housing stability, food security, and access to transportation or childcare directly affect whether a family can fill a prescription, keep follow up appointments, or provide a diabetic child with consistent meals and screenings for these factors. Is now considered a standard part of comprehensive pediatric assessment. Community level factors, including access to safe outdoor space, quality of local schools, availability of pediatric subspecialty yeah, subspecial care and exposure to environmental hazards like lead paint, compound individual and family level risks. The nurse's role is to identify these barriers through assessment, avoiding assuming noncompliance when the real barrier is access or resources, and connect families to appropriate resources. Your exam questions in this area often present a family that appears non-compliant and reward the answer that investigates an underlying access or cultural barrier rather than assuming poor motivation. Um, Objective 8 is students can identify common pediatric health screenings and their recommended schedules. So, routine well child visits bundle a standard set of screenings tied to developmental windows. Universal screenings include newborn metabolic slash genetic screening and hearing screenings before discharge, critical congenital heart disease screenings via the pulse ox, standardized developmental autism screening at defined checkpoints, lead screening at 12 and 24 months, and vision and hearing screenings at intervals through school age. Additional periodic screenings include blood pressure at every visit starting at age 3, hemoglobin and anemia screenings, cholesterol screenings once between ages 9 and 11, TB risk screenings, and age appropriate depression slash substance use psychosocial screenings begin in early adolescence. The nurse's role is administering or coordinating these screenings, teaching families why each matter, and recognize that a missed or abnormal screening triggers a referral rather than being simply documented and set aside. Objective 9, students can describe the nurse's role in monitoring growth and development, including use of standardized growth charts. So the growth monitoring use standardized CDC and WHO or WHO growth charts that plot weight, length, and height, and head circumference against age based percentiles with BMI for age percentiles added for ages 2 and onward. The nurse's core skill is accurate, consistent measurement technique because becomes small technique errors distort the percentile and can trigger unnecessary parental worry or conversely mask a genuine problem. More important than a single percentile is the growth trend over time. A child tracking steadily along their own curve is reassuring, even at a lower percentile, whereas a child crossing two or more major percentile lines downward, which would be like failure to thrive, or upward, which could be obesity or risk for obesity, is a priority finding requiring further workup regardless of where the current point falls. The nurse also correlates growth findings with developmental milestone achievements at each visit, since growth faltering and developmental delay frequently co occur and both warrant referral. Objective 10, sorry. Students can discuss nutritional needs and common feeding challenges for infants, toddlers, or older children. So, nutritional needs shift substantially across pediatric development. Exclusive breastfeeding or iron fortified formula is recommended for the first 6 months, with complementary solid foods introduced around 6 months. And whole cow's milk is not introduced before 12 months due to renal solute load and iron deficiency risk. Toddlers experience a normal expected decline in appetite and increased food selectivity as growth velocity slows after infancy. This is a common source of parental anxiety, but is normal and should be reframed for families rather than treated as a feeding disorder, provided growth is tracking appropriately. Common feeding challenges include toddler food jags and neophobia, um, choking risks for inappropriate food textures, um, in school age slash adolescent risk for poor nutrition from excess processed food, skipped meals, or the early emergence of disordered eating patterns. The nurse assesses feeding within the context of overall growth and provides age specific anticipatory guidance at each visit rather than generic eat healthy advice. Objective 11, students can explain prevention, recognition, and management of common communicable disease in children. So, children are disproportionately affected by communicable disease due to immature immune systems, close contact in group settings like daycare or school, and incomplete immunization status in early infancy. Prevention rests on the routine immunization schedule, hand hygiene education, appropriate exclusion from school slash daycare policies during the contagious period, and standard slash transmission based precautions in the healthcare setting. The nurse must know incubation periods and contagious windows for common childhood illnesses um, to correctly counsel families and prevent outbreak spread. Recognition requires distinguishing classic presentations, the descending blanking rash or blanching rash, sorry, of measles with associated cough slash conjunctivitis and Koplik spots, the slapped cheek appearance of fifth disease, the barky cough, and stridor of croup. The sorry, I lost my spot. The pruritic rash of varicella in successive croups or crops, and recognizing red flag complications that require escalation. Management is largely supported for most viral illnesses, with specific antiviral or antibiotic therapy reserved for indicated cases. Um, your exam, you're going to commonly see like rash slash symptom patterns and ask for identification of the disease or the correct isolation precaution. So make sure you know those. Objective 12, students can identify signs and symptoms in nursing management of common pediatric respiratory conditions. So, pediatric airway anatomy predisposes children to more severe respiratory compromise than adults from the same insult, a proportionally large tongue and narrower airway diameter at the cricoid ring, and more compliant chest wall mean small amounts of edema and secretions cause disproportionate airway narrowing and increased work of breathing. Common conditions include croup, bronchiolitis, and asthma. The nurse's priority in any pediatric respiratory presentation is recognizing escalating work of breathing before hypoxia becomes severe. Nasal flaring, grunting, retracting, tachypnea, and use of accessory muscles are all early warning signs that precede a drop in oxygen saturation, and a tiring, quieting child with decreasing retractions can signal impending respiratory failure rather than improvement. Um, Positioning for comfort, minimizing agitation, supplemental oxygen as ordered, and continuous reassessment are core nursing interventions. Objective 13, students can describe assessment findings in nursing care for common gastrointestinal conditions in children. Common pediatric GI conditions include gastroenteritis, pyloric stenosis, um, intussusception, and appendicitis. Nursing assessment priorities, recognizing dehydration severity, mild, moderate, or severe, using clinical signs, mucous membrane moisture, skin turgor, capillary refill, urine output, fontanelle status in infants, mental status, because dehydration is the most common life threatening complication across nearly all pediatric GI illness. For surgical abdomens, the nurse keeps the child NPO, monitors the signs of perforation or shock, and avoids administering pain medication or laxatives before a surgical or evaluation is ordered. Um, if it's ordered to withhold, examine items commonly present vomiting slash stool characteristics, and during your exam, they're asking you to identify the underlying condition and the priority nursing like actions, like rehydration or something like that. Objective 14, students can identify fluid and electrolyte imbalances and describe appropriate nursing interventions. So, children are more vulnerable to fluid and electrolyte imbalance than adults because a higher proportion of their body weight is water. A larger proportion of that water is in the more easily lost extracellular compartment, especially in infants. Their higher metabolic rate increases insensible fluid loss, and their kidneys are less able to concentrate urine or compensate for imbalance until roughly age 2. This means relatively small absolute fluid losses produce dehydration and electrolyte derangement much faster in an infant than in an adult with a proportionally similar illness. Key assessment findings include weight loss, decreased urine output, dry mucous membranes, decreased slash absent tears, delayed cap refill, tachycardia, sunken fontanelles in infants, and lethargy in severe cases. The nurse differentiates isotonic, hypotonic, and hypertonic dehydration based on serum sodium, since management differs. Hypertonic dehydration, in particular, requires slow correction to prevent cerebral edema. Interventions include oral rehydration, solution for mild to moderate cases, IV isotonic fluid boluses for moderate to severe dehydration or shock, strict intake and output monitoring, daily weights, and electrolyte replacement guides by lab values. You, as the nurse, also should monitor for signs of overcorrection as a safety priority. Objective 15, students can discuss safe medication administration practices in pediatric patients, including dosage calculation. So, pediatric medication safety depends on weight based dosing, which requires the nurse to obtain an accurate current weight in kilograms, calculate the ordered dose, and verify it against the safe dose range from a reliable reference before administration. Every single time, even for a medication given previously, since a child's weight changes rapidly. The rights of medication administration are extended in pediatrics to include right documentation of weight and a mandatory independent double check for high alert pediatric medications by a second licensed nurse before administration. Um, Objective 16, students can describe differences in pediatric pharmacokinetic and pharmacodynamic compared to adults. So the pharmacokinetic, which is absorption, distribution, and metabolism and excretion, differs meaningfully between children and adults, especially in neonates and infants. Gastric pH is higher, so it's less acidic. In infants, altering absorption of some oral medications. Gastric emptying and intestinal motility are slower and more erratic in early infancy. Body composition shifts with age. Infants have a higher proportion of total body water and extracellular fluid and lower fat stores, which increases the volume of distribution for water soluble drugs and decrease it for fat soluble drugs. Protein binding is reduced in neonates due to lower circulating albumin, increasing the free fraction of highly protein bound drugs and raising toxicity risk at doses that would be safer in an older child. Metabolism is immature at birth and matures over the first months to years of life, meaning drugs metabolized by the liver may accumulate and cause toxicity in neonates or young infants at doses safe for older children, while some older children actually metabolize certain drugs faster than adults, requiring relatively higher weight based doses. Renal excretion is significantly reduced in neonates, so renally cleared medications and their intervals must be adjusted accordingly. Objective 17. Students can explain emergency preparedness and response for acute pediatric condition. Recognizing early deterioration in a child requires understanding that children compensate for physiological stress differently than adults. Tachycardia is often the earliest and most reliable sign of compromise, and a rapid silent progression from compensated to decompensated shock can occur faster than in adults. The pediatric assessment triangle, which would be like appearance, work of breathing, circulating to skin, like the circulation of your skin, assessed from across the room before hands on exam, is a rapid, evidence based first step used to identify a sick looking child requiring immediate intervention. Preparedness includes having weight based emergency equipment and medication references readily available, knowing pediatric basic life support sequencing and compression to ventilation ratios, and recognizing that the most common cause of pediatric cardiac arrest is respiratory failure or hypoxia progressing to arrest, not a primary cardiac event, meaning airway and breathing interventions are the priority in pediatric resuscitation far more than in adult resuscitation. Um, Objective 18. Students can discuss the importance of immunizations and address common parental concerns. Immunizations prevent serious, sometimes fatal, vaccine preventable illness and contribute to community slash herd immunity that protects individuals who cannot be vaccinated. The nurse's role includes administering vaccines per the current ACIP or CDC recommended schedule, using correct site slash technique for age, screening for contraindications, and providing the vaccine information statement before administration as required by law. Common parental concerns include fear of side effects and discredited but persistent belief in a vaccine autism link, concern about too many vaccines too soon, overwhelming the immune system, and religious or personal exemption requests. The nurse addresses these with accurate, respectful, and non judgmental information, acknowledging the parents' concerns, providing evidence based facts, and continuing to build trust over time rather than refusing further engagement after a single declined visit, since a respectful ongoing relationship is more likely to eventually result in vaccination than confrontation. Objective 19. Students can identify signs of abuse or neglect and describe mandatory reporting responsibilities. So the nurse must recognize physical, sexual, emotional abuse, and neglect through a combination of injury patterns, history inconsistencies, and behavioral red flags. Concerning findings include injuries inconsistent with the statement mechanism or the child's developmental ability, injuries and patterns suggestive of inflicted trauma, um, a history that changes between tellings or between caregivers, delay in seeking care for a significant injury, and specific red flag injuries such as retinal hemorrhages or subdural hematomas or spinal fractures in a non ambulatory child. Neglect presents as failure to thrive without an organic cause, poor hygiene, inadequate supervision, untreated medical or dental needs, or developmental delay from lack of stimulation. Every nurse is a mandatory reporter and is legally required to report reasonable suspicion of abuse or neglect to Child Protective Services and or law enforcement per state law. The nurse does not need proof, only reasonable suspicion, and reporting in good faith carries legal immunity even if the report is later unsubstantiated. The nurse documents objective findings without speculating on the cause in the chart, ensures the child's immediate safety, and follows facility protocol and notifications. And then objective 20 is students can integrate growth, development, and disease process knowledge to prioritize care for pediatric patients. This objective represents the synthesis point of week one content. So, safe pediatric nursing care requires simultaneously holding a child chronological age, developmental stage, current disease process, and family context in mind when setting priorities. The same interventions can be correct for one child and wrong for another based on these overlapping factors. For example, prioritizing airway breathing circulation always comes first, regardless of age, but how the nurse achieves and maintains that priority is shaped entirely by developmental stage. On integrated higher level exam items, expect to be asked to select the single priority action for several plausible sounding options. The correct answer is usually the one that addresses either an immediate physiologic threat or when the physiological status is stable, the intervention most aligned with the child's developmental stage and the family's role as primary caregiver. Um, it just says practice explicitly narrating your clinical reasoning for each week. One objective: what is the underlying physiology or developmental principle, and why does it change the nursing priority? And that's it. So I'm assuming that they're going to ask questions about vaccines, signs and symptoms of distress in children, especially respiratory, environmental illnesses, vaccine side effects, especially. Autism is not a proven one, in case you thought it was. Mm, childhood illnesses, yes. That's basically going to be the sum of your guys' test. Does anybody have any questions as far as like the material, the test itself? Um, um,
Yeah.
I don't know if I can actually do that. I don't have I don't have your exam in front of me to like give you a visual or help you in any way. Um, so objectives meaning like what's being told to you like as a fact. So like I'm assuming that some of the questions are going to be stating like um your patient is how many years of age, came in for a trauma, and is presenting with subdural hematomas and retinal hemorrhages. What is the objective of the concern of the nurse? That's basically how your test questions are going to be asked. Did that make sense, Kendall? Sorry if that didn't. Okay, perfect. I think it's really going to be straightforward, though. I don't think it's going to be super tricky. I think the only questions that will be tricky is going to be the developmental stages, because if you have children or you see your friends' children and you think that you need to base the question off of experience rather than what your book says, I just don't want you guys to do that. I want you to guys to use the actual stages in theory of what the book's telling you what the developmental stage is, because those will be straightforward, but you just have to know what age goes with what. Because I do know they have questions on there and they are trying to trick you. Anybody else have any other questions or anything? If not, that's all I got.